Good evening, everyone. Welcome back to You and Your Health. We're excited that you're able to join our program this evening. So this evening, we have a very special guest. Speaking of Dr. Robert Entoine, she's a physician and author of several books, a philanthropist, a wife, and a mother of three. And she's a returning guest on this program. So we're so excited that she accepted our invitation. I believe this is the fourth time that she's coming on. So if you're watching the program for the first time, my name is Erika Roberts Hilton, a co-host of this program. And my other co-hosts are Dr. Edward Asuman and Dr. Eddie, are you coming on? Dr. Yvonne Palampudov. Okay, I thought you were coming on, which was like I started stuttering.
All right, I'm
How are
here.
you? Okay, so we're late, so we're gonna go ahead and get started. So Dr. Yvonne is gonna be, she's off this evening, but she'll be on next week. And she has a special guest, so hopefully you're able to tune in, Dr. Gifty Ajamai, who will be speaking about diabetic foot care, I should say. So please make sure to tune in. So our discussion this evening is on osteoporosis. What is it? Who's at risk for this disease, and how can it be prevented? As I indicated, our special guest is Dr. Robert Entoine. She'll be sharing her expertise on this topic. Dr. Entoine is a board-certified family medicine physician with over 30 years of experience. She obtained her medical degree at the University of Ghana Medical School and completed her residency in family medicine in Tulsa, Oklahoma. She has practiced in multiple countries, including our homeland, Ghana, and my father's homeland, which is Liberia, Canada, and here in the United States. She currently lives in Florida, where she practiced medicine in the city of Claremont for the past 15 years. She's an advocate of women's health and preventative medicine, and always encourages her patients to incorporate lifestyle changes in their health management. She and her husband, Dr. Jojo Entoine, has been leading medical missions to Ghana since 2000, providing free medical clinics, addressing women's health issues and educational empowerment, among many other things. She's very active in her church community in Florida and involved in prayer, mission, and hospitality ministries. As I mentioned, she's an author. Her last book, which I have right over here, if you can see it, A Woman's Guide to, I think I'm holding it incorrectly, A Woman Guides to Her Body and Total Health. So we're extremely grateful that she's a busy person, extremely grateful that she's able to join us this evening. So let us welcome back our guest, Dr. Barbara Entoine. Good evening, Dr. Entoine.
Good evening. Good evening.
Thank you again for accepting our invitation again to be on our program. I mean, as I indicated, your book here has a ton of knowledge, and you discuss multiple topics. And so we've gone ahead and kind of went through it and picked the 4 topics, and I'm sure we'll still go through it and pick others for you to come on and discuss with us. So welcome back on You and Your Health. We're a little behind, so if you're ready to start, Dr. Eddie, if you don't mind projecting Dr. Entoine's slides for her.
Well, thank you for having me, and we'll go through this quickly, and then at the end we'll have a time of asking questions and stuff like that. Next slide, please. So we are discussing osteoporosis today, and I'm sure some of you will be wondering, that's a boring topic, it's on bones, so why do we need it? But it is important, because what happens in osteoporosis is that there's thinning and weakening of the bones, and as one grows up and ages, so to speak, bone as we see it is a very active living tissue, and it is involved in building up and tearing down. So it breaks down, it builds up throughout our lives. It does that. And there's always a balance between the two, But when osteoporosis happens, that balance is broken. And you have breaking down, exceeding rebuilding of the bones. And so that leads to thinning, less strength, weakening, and it may lead to breaking the bones. Okay, so that's what basically happens. Next slide. Now, you'll be surprised to know that in the US alone, about 54 million Americans have either osteoporosis or the milder form of it, which we call osteopenia. And not only do you have it in the US, but also worldwide, among the elderly, that is the people above 60, 65 years, about 20% of those people have osteoporosis. And the interesting thing is that the numbers are very high in Asia and Asian countries, and we'll learn why it is so later on. Now, it is estimated that 1 out of every 2 women over the age of 50 will break a bone at some point because of osteoporosis. People break bones due to different reasons. They may fall from a height and so on and so forth. But in osteoporosis, when the breakage occurs, it's usually from a standing position. So it's a soft fall, and then it leads to the break. And we call that fragility fracture because the bones are frail, okay? And it's not because the person is falling from a big height or is in a motor vehicle accident. I mean, if you have osteoporosis, your bones can break when there's a motor vehicle accident and you are involved. But then just an ordinary person who is walking and falls should not break a bone. But if you have osteoporosis, you may break a bone. Next. Now, I mentioned a little bit about bone health, the fact that there's always rebuilding and then breaking down. In normal bone, there's a balance between the two. And then we have osteopenia, which is a milder form of imbalance between the building up and the breaking down. And if you break down more than you build up, then you may have osteopenia. Okay, so just a little bit of the balance is just it's spoiled, but it's a little bit. And then you have osteoporosis, where the imbalance is great because the breaking down is so excessive compared to the bone building up. And how do we know this? We know this because we are able to measure the bone density of the bone, and we use a machine called a Dexa scan machine, and we'll talk a little bit about that in a little while. Next slide. So why is there a big deal? Like I said, there are many interesting topics, and why should we talk about osteoporosis? But it is very, very important because the weakening of the bones may lead to the fracture that I mentioned to you after a small cough. In fact, after a small fall. In fact, some people may even cough and they may break a rib, because of osteoporosis, or they may sneeze and then they break a rib. And so it can happen. They bump into a chair, and because they have osteoporosis, they crack a rib. And so these fractures are very important, especially when they happen in the hip, in the spine, and maybe when you fall, or in the pelvic area. Now, the results of these fractures are why we do not want people to develop osteoporosis in the first place, or to progress from normal to osteopenia to osteoporosis. And that's because they found out that when elderly ladies have osteoporosis and they have a fracture from a fall, say their hip, it decreases their quality of life. They end up being hospitalized, and while they are in hospital, because they are lying down and so on, they may develop pneumonia, and pneumonia is a killer of elderly people. It causes those disabilities. Somebody may crack a hip, and then the repair is done, but because the bone is so bad, the person may end up with a walking cane. the rest of their life or be in a wheelchair. So those are disabilities that can happen. And unfortunately, some people, once they are discharged from the hospital, because they can't walk, they lose their independence. They were at home alone, cooking, doing their everyday chores, and now they've got a hip fracture and they cannot bear weight on the leg. So what happens? They end up in a nursing home, and it can even lead to death, because in the nursing home they'll be lying in the bed. They may try to get them up, they may not have time to get them up. And while they are lying there, bone density is even decreasing even more. They may end up with pneumonia in the nursing home and die. So you find out that according to the research, 1 in 5 person who has a fracture of the pelvic area will die within a year. And then only 1 in 3 people with a fracture may return to their previous level of functioning. So like I mentioned, some may not be able to live independently. And that becomes very sad. And it's just because they've had a fragility fracture. Next one, please. And I thought I'll put this slide in because some people think that it's only women who have osteoporosis, but that's not the case. Yes, 80% of people with osteoporosis are women, but then, and there's a reason for that. One, women tend to have thinner and smaller bones. Estrogen, which women have, it's part of the women's hormones, decreases as we grow older. And at menopause, you find out that estrogen levels fall dramatically. And so, because estrogen helps with bone density, when this happens, then unfortunately, women's bone density start decreasing after menopause. And also, if a woman has her ovaries removed, for example, because of one condition or the other, the estrogens are produced by the ovaries. And so what happens? Again, you have a rapid decrease in bone density. And this may even happen in women who end up having menopause at an early age. There are some women who start menopause between 35 and 40 years. We call that premature menopause. And they would start having bone decrease as the years go by. And the other reason why gender matters is that, as you know, because of genetics factors and so on, women tend to live longer than men. And so because they are entering into their 70s and their 80s, which is when we see the fractures and so on happening, then you have a problem with that. And unfortunately, we women don't also absorb calcium as much as men do. You know, they are able to absorb the calcium they take in and absorb it into the bone. But we women don't do that. And so we have that problem of thin bones. Next slide. So the natural history of bone loss actually begins quite early. People don't realize that around 20, 25, that's when women start losing bone density. And as you approach menopause, then the loss becomes even greater, very steep. Okay, so that's one of the risk factors, age. Women 50 and over, they would have such a big bone loss compared to earlier years. And then we have also postmenopause. Being menopausal, your estrogen levels are low, like we said. And then in the races, they found that Caucasians and Asian women tend to develop osteoporosis faster and quicker. And the reason is, with the Asian women, you see that they have smaller stature, you see, and that's the reason. So their bones are smaller, and so they tend to develop it. And then if you have a family history, say grandma had osteoporosis, then or your mother has had osteoporosis, then you have a higher risk of ending up with osteoporosis. And so it means that your screening should start earlier rather than later. We mentioned how people who are thin and small, and I think I say that this is the only condition where being small is a disadvantage because with many things we talk about, people who are heavy, they experience this and that, and people who are obese, they experience this and that, but with osteoporosis, it's those who are thin who tend to get it. Yeah. And then if you've had a history of cancer and stroke, you with the cancer, you may have chemo, you may have radiation and all that, then that would affect your bone density. And then for stroke, people who have had stroke, sometimes you find out that they are not moving like they normally should. And so that increases their chances of getting osteoporosis. And then there's a type of arthritis known as rheumatoid arthritis, where your cells are fighting against your bones. And so you have a lot of arthritis in your joints and so on. And it looks like the bones are kind of being destroyed, if you see what I mean. And so you are prone to osteoporosis. So other things include lack of exercise or physical activity. We all know that with osteoporosis, one of the ways in which we can prevent it is when we exercise and also do what we call weight-bearing exercises. And that is exercises where you are stepping out, you are walking, you are jogging, even riding bike, all of those, doing yoga, tai chi. Those are exercises where we call weight-bearing exercises because your weight is kind of on your skeletal bones, and so you end up strengthening the bones by those exercises. And then if you have low levels of calcium and vitamin D, you will also at risk of that. And so if you will take anything away from this lecture, remember vitamin D and calcium are very important. And then people who drink and smoke a lot, it also affects your bone density. And those who have thyroid dysfunction, where it is hyperactive, your thyroid is hyperactive. We call it hyperthyroid or hyperthyroidism. Those people may also have thinner bones because of that. And there are people who also take thyroid medicine because they have hypothyroidism. Their thyroid gland is sluggish. So we put them on medicine. And when we put them on the medicine, if they end up taking excessive doses of that medicine, then they end up with somebody as if they have hyperthyroidism. And so the breakdown of the bones exceeds the building up of the bones, which we talked about earlier on. And of course, anybody who has low estrogens may have a problem or have imbalance in the estrogen and testosterone levels. They may have problems with being at high risk for osteoporosis. And we mentioned also that we mentioned the thyroid medicines, but the other medicines that can cause that are steroid medicines. These are like prednisone. These are medicines that people with asthma may use, people with rheumatoid arthritis will use. Some people may also use it if they have a disease known as chronic bronchitis. They are on daily steroid medicine. They tend to have smaller bone density. And surprisingly enough, there's one medicine that a lot of people take, Prilosec, Nexium, Pantoprazole, that people take. It tends to affect the absorption of vitamin D and so on. And so people may end up with osteoporosis. And just as an aside, Some people, they had like acid reflux, and so they were given these medicines, and it seemed to have helped them so much that they've been taking these medicines for, let's say, years.
Yeah.
Some people have been taking it for 5 years, for 2
Mhm.
years. But when you read the literature insert in these medicines, they'll tell you that you shouldn't really take it more than 12 weeks
Oh,
unless you
wow.
have certain medical issues. Like, for example, those who have acid reflux that has affected the lining of the esophagus, and they have something we call Barrett's esophagus. They can be on it for a number of years because Barrett's can turn into esophageal cancer. So they have a right. But if you have acid reflux, for example, what I tell my patients is that unless you have an ulcer, okay, unless they said you have an ulcer and they put you on it, and they go and scan you again and look into your stomach and the acid is healed, they would normally let you either take a lower dose or transfer you to another set of anti-acid medicines known as H2 blocker. And common examples of that are Pepsid AC, um, also known as famotidine. And that we normally will transfer you to that type of medicine because it doesn't do as much damage to your vitamin D and all that stuff like these proton pump inhibitors do. So remember that. Um, and also, another caveat is that some people are on these medicines, and when they stop suddenly, the acid level goes back right up, and so they are not able to stop. So there's a way of de-prescribing these medicines so you don't stop. You go and talk to your doctor about it. You ask your doctor, okay, why am I still on this medicine? Is there another alternative one that I can take? And so on and so forth. So you can, because you have the knowledge. And that's why I'm always talking about the fact that it's important for us to have that knowledge so we can have meaningful conversations with our primary care doctors. Next slide, please. Okay, so we've talked about the risk factors, other medications that may also be an issue are seizure medicines that people take for epilepsy and so on. And some of the older ones are phenobab and carbamazepine and phenytoin. A lot of times, some people have been changed from these to newer ones, but those who have taken this for a long time, you find out that their bone density becomes lower. And we've already talked about the thyroid medicines. And then women who are on Depo Provera, as you know, some women use Depo for family planning, where you go and get your shot, every 12 weeks or so. And if you're on it for more than 2 years, you probably should be taking calcium and vitamin D. And then as you maybe get closer to 50 or so, or 45, 50 years, you should talk to your doctor about it and they can do the DEXA scan that we talked about. And even too much soda and too much salty foods can affect your bone density. So that is very important. Next slide. So, how do we diagnose it? I think we've kind of touched on it a little bit. And what we'll do is that, first of all, your doctor will talk to you. He'll take a history. Have you had a fall where you were just in the upright position and you just fell, you cracked a rib? I've had patients who um, they didn't do any dramatic fall or anything, and then they crack a rib, or they are coughing, they have a chronic cough, they are cough cough cough, maybe you have a COVID and you are coughing a lot, and then you all of a sudden your ribs have cracked. So for me, anybody who has cracked ribs, I send them for a DEXA scan just to make sure that they are not having osteoporosis. And that is as somebody too who may have a little bit of other risk factors. And some risk factors are also, we'll talk about those later. But people with certain chronic diseases, they will start screening earlier than most people, and we'll talk about that. But we'll do a history and a physical on you, find out. And the physical, we also look at your back and see whether your spine is nice and straight and curved at the right places, or you don't have a hump at the back where if you touch you have a little bit of pain there. Um, and that could mean that you fractured a vertebrae or the spine bodies. Oh, yeah. So we can also do lab tests, look for your calcium and vitamin D levels. And there's a certain score your doctor can ask certain questions of you. And with those questions, we come to a certain score known as the FRAC score. And that, if it's a certain level, then they may end up doing the screening early. But the what we call the gold standard is the bone density test, and that is done testing by scanning, doing a test on your spine and your hip bone, and it's usually done in women over 65 years. But you remember I mentioned that there may be some younger women who may have risk factors, and so that those women will start at an earlier age and not at 65. Thank you. Next slide. So this is a picture of a Dexa machine, and it's a very simple test. You lie on this table, and then that arm above the table will come above you, and it will come across like this a couple of times, and then you turn on your side, and it will also do so for your hip. So like I said, mainly the spine and the hip are measured, and then they put it into a formula and everything, and they come up with certain numbers, and you can be diagnosed as normal or osteopenia or osteoporosis. So that's what happens. Apart from this machine, there's a certain special CT scan that is used, but it's very expensive and nobody hardly uses it, except maybe those who are doing research or something like that. People also use ultrasound. So sometimes when you even go to some health fairs, they may have an ultrasound that it looks like, when you see it, it would look like the foot, the foot spa. When you're doing a foot spa, the machine, it looks just like that. And you put your foot inside, and then they put an switch it on, and it will come up with some numbers and so on. But it's not really the standard, because they haven't done long-term studies on it to say that yes, it compares with the DEXA scan. But you find out that sometimes at health fairs or so, they may be using that, and when they find out that it's abnormal, then they would say go for the DEXA scan. But a lot of insurances do cover DEXA scans, so that is the gold standard. I hope you can see these bones. Okay.
Yes.
First of all, you find out that the main areas are the spine, the wrist, and the hip. Those are the places that get the fractures most of the time. And here, this person has got a fracture here. And because of that, the curvature of the spine at the top part, it curves outwards quite a bit compared to the normal woman here, So that's what happens. And if you look at a bone, a cross section of the bone, you have normal bone, and then you have osteoporotic bone where there's a lot of holes in the bones. Yeah. So that's what happens. Next slide. Okay. Here is a fracture of the wrist. That is also one of the common places that you can get a fracture. The spine, like I said, the wrist, and then the hip. And if you look in here, this is like a normal one. Okay, then you come to somebody who has the spaces and large spaces in the bones of the wrist, the upper part of the wrist. Okay, and then they fall and there's a crack. That's the red that you see. I hope they can see it.
Yeah,
This seems to
it's
be
pretty clear.
okay. And then this is what would happen. You find out that there is this swelling, inflammation and redness and pain around this area of your hand. And the hand will be curved in a certain way. We call it the dinner fork curve of the hand. That's what the hand will look like. And that means that you've broken a bone there. Next slide, please. Okay, so we've talked about how fractures are one of the main complications, and we do not want to have it because of all the things we discussed. Pneumonia, ending up in a nursing home, etc., etc., losing your independence and all that. So this is what happens in the spine. These are 3 spine bones, okay? And in between the spine bones, there's a cushion known as the disc. So when, excuse me, when you have a fracture of the spine, and sometimes you may not even, it may just be a cough, severe cough, and then you fracture it. And you see that bone which is fractured, that's this one. And it has some cracks in it, okay? And because of that, it changes the curvature of the person's spine. And then they have a big hump at the top of the spine. So that's what it is there. And what happens with the spine too is that then you lose height. So in fact, one of the questions we may ask somebody is that, have you found out that as you became postmenopausal, is your height shorter? Because somebody may have a fracture of the spine and they may not know it. They may have felt some pain at the back and they thought, oh, it's my back that is probably hurting me, low back pain or whatever. And it may be a fracture. And maybe we went to do an x-ray because you've been complaining about back pain. And when you go, you see that one of the bones is fractured. Some people have multiple fractures, and so it decreases your height because you were tall, now you are bent. So your height becomes decreased. And so if somebody talks about my height has decreased, that's something that we may want to look into further to make sure that they do not have a vertebral fracture. Okay. Okay. And by the age of 80, 40% of all women will have had a fracture. Just think about that. 80 years. Most of us want to live till 90, and so by that time, 40% would have had a fracture.
It's a lot.
It's
That's
quite,
a lot.
yeah, it's quite a lot, Yeah, go on, next slide, please. And then this is the picture. Men also can have osteoporosis. Although women start screening, this is if you have average risk, okay, for any condition. Some people will have an average risk and some people will have an increased risk. If you have average risk for a woman, you start your screening at 65. But if you have increased risk, some of the things we talked about, then your doctor should really start screening you earlier and doesn't wait until 65. And so there's this man, for example, he uses a cane and he was upright and he fell from the upright position. It was not like he was sitting in a car and the car had an accident. And when he fell, what happened? You see, there's a fracture, the hip joint right here. Okay. So that is why it's important and to make sure that we do not end up with osteoporosis, or if we do end up with it, we are treated for it. Next slide. Please tell me, Eddie, if I'm taking too much time, let me know. I think it says 35 minutes, right?
Yes, it's
Yeah.
7 for, yeah.
Okay. So, like I said, you start usually at 65 for women and 70 for men. And like I said, those for average risk. But if you are at increased risk, your doctor should start earlier. Okay. And they can assess you through this FRAX assessment. And it doesn't take a long time to do that. Um, and then they can order a DEXA scan, or if you have some of the conditions we had mentioned earlier, you have a family history, you have had a fracture, which was from um, upright position and so on and so forth, then they would have to send you. In that case, they don't have to even do a fract assessment. They just have to send you to go and do the test. And if you've been on steroids for a long time, and we mentioned the thyroid medicines as well. Next slide. So these are the list of those who need it at an earlier age. I've already mentioned some to you. For example, those with low body weight. I think Asian people start earlier than the 65, because they have a high chance of getting osteoporosis. And Caucasians, those who smoke, those who drink excess alcohol. We've also mentioned those with a family history of osteoporosis, history of rheumatoid arthritis, history of a stroke, even those with diabetes, okay, can have that. And so these are some of the disorders that you are strongly advised to go for early testing. Diabetes, hyperthyroidism. There's another condition called hyperparathyroidism, early menopause. We've already mentioned. We've mentioned chronic administration of certain medications, and also those with malnutrition and malabsorption. There are some people who cannot absorb the calcium and the vitamin D well because they have gut problems, and so they may have to have early screening at an early age. And even those with chronic liver disease like cirrhosis. Next, please. So how do we treat it? Okay, so there's a dual approach. We call it lifestyle approach and medication. Okay, so those are the two things. With lifestyle, it involves exercise and diet, what you eat. And remember, when we talk about diet, we are not talking about you going on a diet to lose weight, but diet is healthy. Okay, so your diet should contain enough vitamin D and calcium. Okay, some people don't take enough calcium containing foods, and so they may need to use calcium supplements. And the thing too is that, as you know, one of the ways of getting vitamin D is through the sun. Okay, unfortunate thing is that those of us who are black, we don't absorb the sun rays very well, which reacts under our skin to form vitamin D. That's the main source. And then for those of you who live in the north, okay, you may have long months of not seeing the sun, okay, and then those who cover themselves, like the people in the Middle East who wear the black, they wear the black what do you call it,
7
clothing,
days.
yeah,
Yeah.
not just the head, but yeah,
Right.
but, like when you go to Dubai and so on, and that kind, they also suffer from um high osteoporosis rates, and yet there's so much sunshine around them. And even in Florida here, the funny thing is that when I see my patients and I tell them they are low in vitamin D, they say, "Oh, but I'm in the sun all the time." But that's a lie, because those of us in Florida, because it's too hot, what do?
Mhm.
We
Stay
come inside
indoors.
to the air condition, yeah. So we don't spend enough time in the sun. You're there, you get from your car, you run straight into your house to get into the air condition. So that is the problem. So it's like nowhere cool. Whether you live in the cold climate or in the hot climate, you are still not getting enough vitamin D from the
Yeah.
sunshine. Okay, so what does that vitamin D does? You know, calcium is so important for this bone density. So what vitamin D does, it helps with absorption of calcium. Okay, and we have two vitamin Ds mainly, vitamin D3 and vitamin D2. D2 is mainly got from plants. Okay, and that is not absorbed as well as D3, which we'll get from dairy and stuff like that. And then we talked about the exercise when you are
Mhm.
walking. That's what we call weight bearing exercises, because you are stamping on the ground. Your foot is stamping on the ground, so you are weight bearing, and that helps you. Um, and then also another thing that can help your back is what we call core strengthening. And with that, it strengthens your abdominal muscles, as and your so you have your back also gets strengthened, and that makes the spine stronger. Okay, and then balance exercises, the big balls that you can sit on and balance on. When you balance exercises, you do balance exercises, it makes you less prone to stripping and falling and so on and
Yeah.
so forth. Next slide. So the food sources, we all know dairy sources like
Mhm.
milk, cheese, yogurt and all that. And then for those who are not milk drinkers, you can also have the other milks like the almond milk, soya, oat, rice milk. They've been fortified with vitamin D and calcium. Okay. Soya milk also has, some tofu also has, because they've added some calcium to it and so on. And right now, even orange juice has calcium added to it. And
Mhm.
cereals also have calcium added to it. So in this part of the world, we have many sources of foods that are may naturally not be have enough calcium, but it's been added to it. And then your fish, canned fish, especially fish which you have the bones in it, they are high sources of calcium. And that includes tuna, sardine, salmon, mackerel, and so on. And when you come to the vegetables, the greens, spinach, cooked spinach, the collard green, broccoli, and okra has quite a bit of calcium in it, which most people don't realize that. And then, last but not the least, you can take supplements if you are not getting enough from all of these sources. Next slide. And vitamin D, we've talked about how it's used in fortified dairy products. And then you have your fish, and then egg yolks are high in vitamin D. And then we talked about how your skin makes vitamin D when the sun shines on it. And then the thing I do is that when women are actually right now, it's not just even women over the age of 50. Some of us are even measuring vitamin D in a lot of people, because there's such a high rate of vitamin D deficiency.
Mhm.
The normal intake is what we call 800 to 1,000 international units. But to be honest with you, when people are deficient, the normal range of vitamin D is 30 to 100. For postmenopausal women, they are saying even you should be closer to 50 to 100. And so if they measure your vitamin D and it's low, then they have to supplement. You have to take supplement. And like we said, D3 is kind of better than D2. So you can take D3. And to be honest with you, when we are supplementing you because you are low, you end up with higher doses than the 800 to 1,000 that I have there. At least for postmenopausal, I'll put you on 2,000. Some people are on 5,000 because their D is so low. You measure somebody's D, it's 18. You know, last time, not too long ago, I saw somebody whose D was 9, you know.
Wow.
Yeah, so I made them come in quickly, and they went on 50,000 units of D once a week, okay, which comes up to about 35,000 a day. And you would see that in 6 to 7 weeks, their levels will go up to about, 40 or something like that. And then after that, we put them on the lower dose. So that's what we do for patients who Ds are low. Next, please. Yeah. So we talked about lifestyle changes, which is the exercise and the eating right. And then the next thing is medications. Once your DEXA scan is done and it's at a certain level, remember we said it could be normal, osteopenia, or osteoporosis. If it is osteoporosis, if it's osteopenia, usually we'll let you do vitamin D and calcium, especially if your vitamin D is low. Okay, so you may take that for a year, and then we may repeat it and see what is happening. A year or two. Is your DEXA scan level better, or is it still going down? If it's still going down at osteopenia and you are close to osteoporosis, we may even start you on medicine, but you start on a lower dose than somebody who has osteoporosis. So once you've done the test, it's decided that you have osteoporosis, and you've failed calcium and vitamin D. If you had osteopenia, then what we'll do is we'll put you on medications. A lot of these medications, you take them either once a week, and they are pills, they are injections, and there's even a nasal spray. And for the pills, there are some that you take once a week. There are some that are taken like once a month. The injections, there are some taken once a month, or there are some taken every 6 months or so. So there are a variety. And depending on how bad your osteoporosis is, your doctor will choose the right dose for you. Common ones that you may have heard of is Fosamax or Actonel. Those are, and Boniva. Those are the three common ones that are tablets. And then another estrogen-like product known as Evista is used to treat osteoporosis. Then there's an injection known as Prolia, which is given once every 6 months. Now, whatever one they choose to start you on, you have to take calcium if you are low in calcium, and you may need vitamin D supplement. And what happens with these medicines is that they kind of get incorporated into the bones. Okay, so that's what happens. What are the main side effects of these medicines? With the oral ones, okay, there's a way you have to take it, because a lot of people may end up, when you take it first thing in the morning with a glass of water, you don't lie down. You have to be upright. And you have to wait half an hour to an hour before you take the rest of your other medicines, because sometimes it causes the esophageal reflux that we mentioned. So you need to let it go into the stomach, be absorbed before you take any other medicines. Okay, so I think that is the last slide. I think I have talked too much. We have to look for questions.
It's definitely good information, which is why Dr. Eddie and I would like to keep on.
Okay.
Dr. Eddie, do we have any questions for Dr. Entoine? while we wait, I have a question or two for you based on the discussion that you just
Okay.
had. You mentioned that younger women who may be predisposed because of familiar history will need to have the DEXA scan sooner than
Yes.
the average 65-year-old woman. And I'm just wondering whether, if you know, the insurance will cover that based on the family
It
history.
also would depend on how the doctor writes it. You know,
Okay.
you may have to get pre-clearance, uh, pre-authorization, as we say. But if they list all those things, nobody can, you know, fault you for going for an earlier DEXA scan. It's like somebody who is asthmatic. They've been asthmatic since the age of 20. They've been on steroids to control their asthma. You know, such a person would have an early DEXA scan, maybe around 35 or 40 years, so that you have a baseline even for them. And then somebody who, like I said, though, if you are on Depo shot, for example, it's good to be on calcium and vitamin D in the first place. But if you've been on Depo shot for 3, 4 years, you you can go for a DEXA scan, and your doctor can make a case for you,
Okay.
so that you get an earlier one. And the more risk factors, the
So
more
they
likely
said
they
they
would
will pro.
cover it. Yeah.
Okay. And also, I'm just wondering, in terms of antacids, folks typically tend to buy those over the counter. And I
Mhm.
was wondering whether that has, in terms of the side effects that predispose folks to osteoporosis, is that something they should be concerned about, or is this only the ones that are prescribed?
Yeah, they are actually Prilosec is over the counter now.
Okay.
Yeah. And so when you look on the Prilosec bottle, it will tell you don't take it for more than 14 days. The one you are buying over the counter. And the only and it's not that it's bad. The only reason is one, they don't want you to keep taking it and you don't know the exact cause of why you are having the acid reflux, and that you should be seen by a doctor and so on. But once a doctor sees you and says, okay, maybe you should do the 20 milligram instead of the 40 milligram, and they have to, unfortunately, sometimes doctors are so busy that they forget about if it's over the counter. Some people don't even list it as a medicine. You know, so somebody is taking over the counter Prilosec, but they don't list it as a medicine because some people think that the only medicine is what you get from the doctor. But if you're taking Prilosec, and even right now, pantoprazole is also over the
The
counter.
counter. Yeah.
And if you are taking that, you know, and you don't tell your doctor, and you don't, you end up with, um, you end up with osteoporosis earlier than other people. And, you know, like I mentioned, it's not just the decreased bone density. If you take Prilosec, Nexium, all those medicines for too long, you know, because when you kind of stopped, the reflux became worse. You know, there's a way in which we can taper it off, and then we introduce something else which does not cause that. Um, and so you need to discuss it with your doctor, and just don't, because it's over the counter, you're not telling your doctor about it, you know. And if you don't tell, they don't know. Yeah.
Yeah.
And so that's why I will replace Prilosec, Nexium, pantoprazole with the other one, famotidine, which is Pepsid AC. That
Okay.
doesn't cause that issue.
Okay.
Yeah. Hmm.
Okay. Dr. Eddie, feel free to interrupt me whenever you have a question from a viewer. Another question, you spoke about malabsorption and
Yeah.
malnutrition, and I was
Hmm.
wondering whether, individuals suffering from anorexia and bulimia,
Oh yeah,
um,
they are prone. They
they
are
are
prone
prone
to
to.
osteoporosis. You're exactly right, because they are not absorbing a lot of nutrients, including the calcium, the vitamin D, and so on. And you see how thin their bones are. They look very thin
Yeah.
because there's been a decrease in the bone density. And also, because of that, their periods become very irregular and their estrogen levels get low. And so that adds on another dimension to it. So yes, people who have eating disorders and people who have um, we have certain bowel diseases that are chronic, yeah, ulcerative colitis and so on. They are not absorbing a lot of minerals, including that. So they may be prone to that. Yeah.
Like inflammatory bowel
Yes.
disorders as well.
Yes, that's it. Yeah.
Okay.
That will be that. I know that when we discuss something like osteoporosis, it's not like diabetes and so on, which is very common or people know about it. But I think that it's a good topic to have discussed because of the fact that you may not see things right now, especially if you're at average risk. Of course, those who are at increased risk, hopefully they've learned that, oh, because I'm on this medicine, maybe I need to be checked earlier and so on and so forth. But we need to, once you're postmenopausal, the estrogen level goes down, and so when it does that, then you start losing the bones so quickly. Yeah. And that's why we have to be proactive and make sure we are doing the weight bearing exercises. Let our doctors check us for vitamin D. Usually calcium is checked in most labs, but it's the vitamin D that is not checked in most labs. So in being proactive, you will ask your doctor, please, postmenopausal, can you check my vitamin D just for me, just to make sure that I'm in the good range, and they will be happy you asked, because they'll wonder, oh my, this woman has been reading or has been, in touch with things. Yeah.
Yeah.
So that's what I would say.
Yeah. I think folks typically associate osteoporosis with family history or postmenopausal, but you brought up many, good discussion in terms of medications. I don't think people typically associate that with medications causing that, or certain diseases. For example, cancer, prostate cancer. So my last question to you is that if a male has a family history of a prostate cancer in their family history, should they then think that they could be predisposed to osteoporosis down the line?
Oh, you mean they had a family history?
They have a family history.
Oh, but they don't.
Yeah.
Not really.
Okay.
Not really. Yeah, I don't think so. It's when the cancer is in yourself most of the time, and that you have the problem, because you may have undergone certain treatments that have affected your bones, basically. Yeah.
Okay.
Yeah. But the stroke, it's because people have lost, maybe mobility in one leg, as not as much. And maybe they are sitting down a lot, not exercising and so on, then they may have a problem.
Okay.
Yeah.
Well, thank you. Thank you so much, Dr. Entoine. Dr. Ed, did we have any questions, or are we done?
Yeah, we have one.
I was waiting for you. That's why I kept talking. Can fluids be introduced in the knee region to form some sort of cushion to prevent the usual bone to bone rub coming in?
Okay. So this question is talking more about osteoarthritis. Yeah, osteoarthritis. That's when the cushion, we showed some cushion in the spine. It's the same cushion you have around the knee. You have the cartilage which forms a cushion. And with age, you find out that, that cushion becomes porous, and it starts decreasing in size. And so they call it bone upon bone, bone upon bone. Yeah. In fact, me right now, my right knee, I think I'm having bone, not bone upon bone, but I think I'm having some arthritis there. But then you have the pain and all that, and they'll do the x-ray, and then they would say you have bone upon bone. Now remember, that is different. Osteoarthritis is different from osteoporosis. Okay. And with osteoarthritis, they do different things. They may let you start with some pain pills, like, ibuprofen and all those kind of things. And when they don't work, you may do physical therapy. When it doesn't work, they will inject it with steroids. And they also have certain other medicines that the orthopedic will inject there, which is non-steroid, but they believe it can help. There are all kinds of things, um, taking your blood and taking the plasma out and injecting it into it, hoping that it will help cushion the bone on bone. But then if it doesn't, then you don't have any alternative but to have knee replacement surgery. Yeah.
So, how frequent should one have a bone density test?
Yeah, that's a good question. It depends. If you are normal, okay, then your and well, when I say if you do the test and you are normal, um, your bone density is in the normal range, you'll be encouraged. Oh, remember to do your vitamin D, your calcium, etc. Eat well, and you may not repeat it again in 3 years or so, 3 or 4 years. Now, if you are osteopenia, then after you see the doctor, they would probably say, okay, let's make sure we are doing the calcium, we are doing the vitamin D. They will check it. And then in a year, they may repeat it and find out, are you going down? Are you going up? Okay. And then if you are on medicine, okay, and I'm digressing a little bit because for the medicine, you have to be on it uh, for at least 5 years, and you get a drug, what they call a drug holiday. Okay. And in that way, for about 2 years, you'll not take the medicine again, but they will be monitoring you with the tests, on a year to year basis. If you have osteoporosis and you're on medicine, we normally do it year to year to just see how things are going, because you may fail a drug. You may be on a certain drug and you are not improving. So what happens? You may go on
Right.
Prolia,
Yeah.
which is every 6 months. So that's how it will be monitored, just like any other disease or condition.
Yeah. Okay.
So, someone is asking that she is at her menopausal age and she was given a home replacement therapy, and would it prevent osteoporosis?
Oh, hormone replacement therapy. That's a whole new topic. Yeah. It does have estrogen. Okay. So, like we said, estrogen helps, but gone were the days when we used to use estrogen as treatment for osteoporosis. But if you are on estrogen for hormone replacement therapy, it will help you. You know, this is one of the things it will help, apart from the hot flashes and all that, that it's going to help. This will help you. But
Mhm.
they do not advocate somebody who is just been diagnosed with that to say go on estrogen. You see what I mean? But it will definitely help the person because it will help build up the bones. Okay. And that is why premenopausal women don't have too much of a problem, and the problem starts after the estrogen levels go down. So, yes, you're using it for something, but it will definitely help you with that.
Okay, I think someone wants a brief statement recap.
Okay.
Are there differences between osteoporosis, arthritis? What do
Similarities
you
or differences, if any.
Oh, okay. So we've
Oh,
talked about osteoporosis, that it has to do with the bone density. Okay, the bone gets thin and weak, so it can easily break. Osteoarthritis is wear and tear of a joint. Okay, so osteoarthritis has to do with the joint. Okay, a joint usually is two bones, and then there is something in between like a cushion. Okay, the knee is such a joint. The hip is such a joint. Okay, but You can have osteoarthritis of the hip. You can have osteoporosis of the hip, but not the hip joint. It's the hip bone.
Bone. Yeah.
Yeah. But the arthritis is of the joints, the two bones that are coming together. That's osteoarthritis. And then some rheumatism that they are talking about, rheumatism used to be a term that we used to use for anything bone. But right now, when somebody talks about, for example, rheumatoid arthritis, that is arthritis, a special type of arthritis where um, your your cells, okay, turn against your joints. Yes,
It's more
some
of an
cells in
inflammatory
your body.
process.
Yes, they see your joint and they say, "Oh, this looks like a foreigner." Okay, and so they accumulate in that place, and when they do that, they cause deformity. A lot of people, when you look at their hands, they have deformed if they are not treated early. It's difficult to walk, etc., etc. Okay, so that is rheumatoid arthritis. It's an autoimmune disease. Autoimmune means that your immune system turns against you, the body. So that's what it is. And so that's rheumatoid arthritis.
Yeah.
Osteoarthritis, we've talked about, it's a joint disease. And osteoporosis and osteopenia, they are bone
Bone disease.
diseases. Yeah. Yeah. Yeah.
Thank you.
It's a good question. It's a good
Yes.
question. Yeah.
Yeah. Thank you so much for the clarification. Dr. Eddie, do you have any more before we let Dr.
No, there
Entoine
are
go?
no more questions.
Okay. You didn't display who was watching this time. It's nice to see all those people popping up. But thank you so much, Dr. Entoine, again.
You are most welcome.
For
It's always
excellent
a pleasure.
presentation.
Yeah, it's always a pleasure to come in and be of some assistance to
Yes.
the Methodist Church.
And I think you dispelled a lot of myth that people might have thought that this was quote unquote a Caucasian disease, and if you drink
Yes,
milk, you will be okay, and things
yeah,
like that. I think.
you can have, although those races, the two that I talked about, Asian people and Caucasians, let's remember that if you have higher than normal risk, then you are at increased risk.
Yeah. And then you
And
have your book here.
Mother's Day is coming.
Yes.
So please get the book for your relatives, and all of this that I shared with you is in the book.
Yes. It's definitely a great guide. As I told them, I have my copy here. It is thick. It has a ton of information
Yeah.
on every disease type. So definitely do check it out. It is on Amazon as
Yeah.
well.
Yeah.
Or you can go through Auntie Jane or myself, and should you desire a copy of the book. So thank you again, Dr. Entoine. Hopefully, Dr. Eddie, you bought one.
Oh, yeah.
You didn't tell me that. That's a surprise.
He knows he cannot be facing me each time and not get a book.
That's awesome. But thank you again, and we certainly look forward to having you.
It's always a
Hopefully
pleasure.
very, very soon.
It's always a pleasure. And thanks for having me.
Likewise.
Good
Thank
night.
you to your family as well. Good
Yes.
night.
God bless. Bye-bye.
Bye-bye. Oh, Dr. Eddie, you surprised me. I'm always the one going like this, and you have your own book as well.
Yeah,
That's
I have
good
one,
to know.
and I'm getting it for a Mother's Day present.
Oh, that's awesome. That's awesome. Well, let's get off the church's platform. We've taken a lot of time today. So hopefully, family, you gain a lot of knowledge about osteoporosis from our discussion this evening. As we always do recommend, do share the link with others so they too may benefit from it. As you heard, the disease is not necessarily a woman's disease. Men also get osteoporosis. And so definitely do pass it on to both men and women. Thank you again for watching our program. We'll be back on May 3rd with a new guest, Dr. Gifty Ajamai, for a discussion on diabetic foot care. Thank you again. And again, if you have any questions or concerns, please send it to emcuandyourhealth@gmail.com. That's emcuandyourhealth@gmail.com. As always, please stay safe, and thanks again. See you next time. Bye-bye.